Hey, Dr. Malone, August. Goodness.
We wish we were in August, or we wish we were in August.
Well,
Fast forward.
I hope we're not dealing with this in August, but April 21st, it's Tuesday. We're here in downtown Pensacola. We're in a different. Hey, Dr. Malone, August 20th, April. We're in a different. We wish we were in August, or we wish we were in August. Well, we're not dealing with this in August, but April 21st. And it seems like to me that we're in a different room because we decided to move from the back in the studio up to the front conference room so I could get a better view of the streets and how many cars are on the street. So I'm looking right now north on Palafox. I'm looking north, and I can see New York Knicks and Global and V Paul's off here to the left, and there is 1, 2, 3, 4, 5, 6, 7, 8 cars parked on the west side of the street, and 1, 2, 3 cars parked on the east side of the Palafox. I'm just talking about that one block here between Romana and Garden. There has been a lot more traffic on the roads today. It seems like people have already just decided they're gonna be done with this stay-at-home deal. We're obviously working remotely still for this. This is the 6th week, and we have everybody scattered around town in their home offices. Fortunately, we're able to sign up 2 new clients today from CarRex, and we're able to do it via Zoom and some other apps that we use for signatures, which were really good. Another car just parked on the east side of the street. I guess they're picking up food, potentially, hopefully. In any event, I noticed last night after we finished, there were several national newscasts on different channels, CNN, Fox, and MSNBC, which I was flipping through last night. I noticed they were talking about some of the same things we were talking about in our video yesterday. But what I'm hearing consistently today, most recently from Governor Cuomo after meeting with President Trump, and I did not hear the White House's press conference this afternoon. It may still be going, actually. Is it?
It's over now.
It's over. Yeah, it's over. Was that Cuomo was basically beating the drum that we've been beating since day one, which is, hell, you can't really open back up until you have testing. And so that's where we are. That's where we are as a firm. We actually found today a place where you can order a test, and Dr. Malone is going to try to get us one somehow. And if we get it, I don't know how long it's going to take. Maybe we can expedite it, but we're going to try to do the test on you online as soon as we get the test to see how easy it is. But it's $100, right?
Yeah, I think it's 119.
Does that include the lab processing and all that, or not?
Yeah, I think because you're buying it through LabCorp, and so you do the home test, the collection, and then you basically drop it off at a LabCorp in your area, and they, depending where you live, they let that LabCorp know to anticipate that test being turned in by you. So it's all paid up with that $119 plus. I'm sure there's a shipping fee.
Well, I guess my question would be, and some people may have this question: if you have health insurance, would health insurance pick up any of that?
The news I saw today with the FDA approval of that test did not comment about health insurance or not. I assume it's maybe one of those situations where if you submit the bill to your insurance, they may pick it up, or you could pay for it with like an HSA or something like that. But I don't think that if you're just saying, hey, I need to do it on my own without a provider, deciding whether or not you warrant the test, they're basically putting it in a layperson's hands. They're basically saying that $120 is on you right now.
Yeah, I think it's probably a pretty good gamble that by the end of the day, when all this is said and done, I think the insurance company is going to have to end up paying for those. All right, so where are we as a community today, Dr. Malone?
So locally here, Escambia County is at 340 positive tests. We were 315 yesterday. The percentage is kind of creeping up, meaning the amount of tests that are being done are coming back more positive. And that's not necessarily to mean that there's more out there. It's just that the testing pool is changing. So that's kind of what I mentioned earlier this week, where you're going to see that there are a greater proportion of sicker people showing up to hospitals, for instance. That's not to say that everybody's getting sicker globally. It's to say that maybe there's some people that are riding this out at home, or consulting with their physicians who are more in a position to say, hey, you can stay home with this. So I think it's a testing pool issue, but it's 7% right now since this all started. But I think over the last day or two, I think the percentage of numbers are coming back saying that 10% positivity, but that don't be alarmed by that if you do see that. Deaths in the county are up to 10 last I saw. We were 8 most recently prior to that. And then the nursing home affected cases are 71 in the county. And again, we were 58 on Friday, so it's jumped up. And
Wow.
I anticipate that we will probably see another jump. What I saw in the news today was that one of the facilities, Southern Oaks, I believe, had some on-site testing going on. And I don't know that I heard all the details, but you would imagine that maybe they're testing a greater portion of the employees or the residents of that facility. So you may see a leap there, both in the county numbers as well as the long-term care facility numbers. And then the county, through Community Health of Northwest Florida, is going to start having the mobile testing units. I don't know if you saw that. They're going to have 2 of them in I guess the housing, let's see what they call it. It's some of the housing in the area of the public housing. And so it's going to be like Addicts Court was one of them. And the other one was, let's see here, Morris Court. And they're going to have basically walk-up testing. And so, you change your testing pool when you do that, because people are more apt to come. Oh, and let me add to this. There's no pre-screening. So if you're walking by and you want to get tested, you're going to get tested. Remember when
you
this
don't have
all
to pay
started?
$100.
No, And remember when this all started? The idea was you had to call, and it was initially Sacred Heart, and you had to get through their phone triage, and then, hey, you got an appointment, drive up in your car, we'll test you. So
Right.
all that's been removed. So that's how the testing pool is going to change. So I expect there's going to be more tests, and we may see more infections with it, these people that are the asymptomatic carriers. So this will be interesting to see what comes of it after they're opening this up tomorrow from 9 to 1, it says, at Addicts Court, and then on Friday at Morris Court.
Who's paying for that? Is that a state thing?
It's through the Community Health Northwest Florida. So I guess those are public funds from a variety of sources. So yeah, it's probably some state or county funding, along with, I know there's some of the hospitals, I think, pay into that fund as well locally.
Mhm.
So that'll be probably a little bit of a change in the stats that we see locally here. But I guess if anybody's watching and they feel they need to be tested, maybe it's a little more convenient for testing if you are able to get to one of those 2 locations easier than you are a hospital, for instance, or one of the test sites. So that's what's going on locally here. Our social distance score is still hanging out at a C-, which again is like the highest it's been in like over a week. And the state of Florida is also the same. So no changes there. What I wanted to, you want me to move on to some of the things I had gotten here over the last 24 hours? So yesterday, I know we talked a lot about, we need more testing, and there's a group that's I've been following this along. I just hadn't got to the point of sharing this yet. And it's more impressive now that you look at this. So this COVID tracking project, it's like a voluntary effort. And so they're pooling all of our data, and it's just real easy to digest this. So the top line is Tuesday, today. There was 151,000 new tests in the country. And it goes across the top line, and we've had just over 4 million tests in the country. So you can see the interval every day. We're over 100,000 new tests. And,
yeah, but we need to be at 500,000, right?
Oh yeah, no,
Our population.
That's my point. So this data is here. So when you start saying on a public safety level, when you're going to start unlocking things, I think this needs to be one of the components. whether it's the governors or any of the feds saying, hey, that we're still not there yet. We need to do this slowly and kind of follow these numbers along with some of the other parameters they're using. But this data is out there, and this is probably one of the most digestible or consumable charts that I've seen. And they break it down by state. It says 56 states because they're using some of the territories, and then like DC's in there, Samoa's in there. So we'll link this here today if people are interested, and it's a pretty user friendly. You can look at your state and all that. So if you start wondering, are we actually doing more testing? These people are really doing a bang up job with their publications. So check that out. So I just wanted to start with that initially. As far as the unlocking, which kind of parlays into what I want to talk about. So locally, Mayor Robinson put out that he was gonna, I guess, propose a system where it was like a green, yellow, red, like warning color to apply to how much to unlock. And green being, hey, we can start doing some of these elective procedures in hospitals. Hospitals can start loosening up some of the resources. So right now there's 220 ventilators in the county, and they're saying there's 175 of them available. So that was, if you remember at the outset, hey, we got to hold on to these ventilators, that we can't be doing elective procedures, that someone might end up staying the night on this because they can't get off the ventilator for the procedure, whatever. So, do you kind of bleed out a certain percentage of the ventilators that are available and say, hey, this is how many ventilators can be used for elective procedures in the next handful of days. And then you ration out your operating room time with the surgeons, and everybody kind of starts sputtering along here in a good direction if they want to think about opening things up. Same is true with the hospital beds in the county here. There's 1,300 beds in the county, and they're saying there's 600 available right now. So you start saying, hey, if it's an elective procedure, someone's going to stay the night, you don't say, hey, we can do 600 procedures today. You say we can do 100, knowing that we can absorb some days, in this county-wide. So I think that's kind of I think that would be the sensible way to go about it. And from what I've been reading, that's kind of what I know Mayor Robinson is leaning toward, as well as some of the other state and federal officials.
So use the hospital resources as a way to guide whether or not you need to slow things down.
That's one of the parameters, and the other one is first responders. So if the local law enforcement is saying, hey, listen, like we have this amount of people that are calling out sick or not available, then that's also another parameter to say, hey, we need to go from yellow to red. We need to go back up, and we need to lock things back down a little bit. The hospitals may be ready to go, but we're not. So all systems need to be ready to go. So that was just the one medical one I was able to speak to, but I know that there was mention of some of the public services, I guess, and law enforcement as being another parameter among many other things. So I think that at least locally in the city of Pensacola, I think there's a measured approach to it on the initial press release from yesterday. And I'll be interested to see how it's embraced and how it's actually rolled out.
Yeah, my concern would be, okay, let's say you open the beach up. If you don't control how close people are parking each other, how close they're laying with each other, different groups, then I think you're going to have, a playground for this virus. It's almost like they need to go out to the beach and block off every other parking space so that there's distance between each car, and then sort of try to control the ingress and egress to the beach. Mm-hmm. And then have a sign up that says you need to be at least 6 feet from the next group of people. Because I think it will allow everybody to, we have plenty of beach. If you include everything down, east of Portofino, there is a lot of beach that direction. I mean, hell, Memorial Day, we have hundreds of thousands of people that visit, and there's still plenty of beach left. So there's plenty of beach out there to spread out. We just got to use it all. And so I think we need to encourage people to use the entire stretch of beach and to try to keep distance, and especially in that parking lot, not to congregate, that kind of thing.
That and the bathrooms and like the shower.
Maybe you can close the bathroom. You can't close the bathrooms, but
No.
Maybe restrict it to a certain number of people at a time, and then just like they do at stores, have a little the pavement marked in front of the bathroom door, 6 feet, and so that people are spread out to wait. You know, there's not 25 people in the bathroom at one time. I think that's a good point. But
Yeah.
there's a lot of planning that's involved in this. I think that's what I'm suggesting, and I'm not sure that it's happened yet. But of course, I hadn't been paying attention to what they've been doing in regards to the beach access. But I did think today, some people may have questions about insurance policies, especially business owners. As a matter of course, we went ahead and filed our business interruption claim with our business carrier. And the way the policy is written, some of them have exclusions for virus and fungus related events. My policy did not, but my policy does, the wording is that the property itself has to be physically affected by the virus. So one of the questions that they ask is, did anybody in your business contract the virus? Because if your business itself is physically impacted by the virus, i.e. one of your staff members was sick and you had to shut down because you had to clean the place, disinfect it, had to send everybody home, and you lost some revenue because you had to do that. In a lot of policies that don't have exclusions for virus, that would be a covered event, okay? Here's the issue though that I thought was a little bit odd. When I was talking to one of the adjusters about our policy, they said, well, you know, when there's a hurricane, we cover that because your building is physically impacted by the storm. And it's not just that clients can't come to you, your building actually has a physical impact. Well, if you do happen to have somebody with the virus that physically impacts the actual business, it seems to me you got the same argument. Yeah, they can't reach me after a hurricane either because they physically can't get here. So driving is less after a hurricane. You have less wrecks because less people are on the road because they can't move in their cars. It's sort of the same kind of argument, but in any event, if you have a business and you have a business general liability policy, as a matter of course, you should probably go ahead and file a claim and let them deny it in writing. And then as things progress with this, I know lawyers, we're not going to handle those kind of cases, but we're certainly going to refer out to other firms that handle these cases. If you have a claim that you think should be paid either by the policy language, or you have somebody in your business that actually contracted the virus, you had to shut down. I think if you can link, if you will, your business directly to somebody that had the virus, I think there's an argument to make that even though a lot of people couldn't come to your business because they were shut down, the fact that you had impact makes it questionable as to whether or not you should be able to claim more than just for that business day. So anyway, that's just something I thought about earlier today and I wanted to bring up from a legal standpoint. Go ahead, Dr. Malone. Did you have some other things you wanted to share with us?
Oh yeah, absolutely. So last night, some of the discussion led to, you know, how do you handle the immense rollout of something like a vaccine when that time comes? You know, you were talking about, you know, how many syringes and needles, and, you know, you even bantered on, like, you know, how would you use polling stations like precincts and things like that? Well, just so happens that HHS has, let me pull this up, HHS has a pandemic guide, and it's like 350 pages. We will not be going through that today, but we are going to link it for you all. So there's a pandemic guide, and it's from 2005, and it'll pop up on here in just a second. So they have this, okay, and so it's an interesting read. It's meant for professionals, but it's pretty easy to get through by the lay community, especially if you've been watching the news. And they go through everything. It's fascinating. And it's the whole strategic plan about preparing for the pandemic, what to do in the middle of it, how you get the vaccine to people. And they basically, in their layout, suggest that the vaccine goes to medical professionals first, people on the front lines, and then the at-risk populations and all that. So as much as, like, for instance, I would want a vaccine, according to the plan that they have in place for a pandemic in 2005, I probably am not going to be one of the first groups of people that is allowed to get the vaccine even. And I think that might be the answer to, needing 6 million vials at one time, or 6,000 syringes or whatever. But they have an entire workforce that's involved in getting the vaccines done. So it's worth the read. But
so you're saying that the vaccine, if there is one, is not going to be rolled out all at once. It's going to be rolled out in phases, starting with the most at-risk people.
If they follow this is HHS's plan. I mean, I have to imagine that it hasn't changed a whole lot. I mean, obviously it's been 15 years and technology and advances are there, but some of the same.
I guess the only issue with that would be if society's back open.
Mm-hmm.
And we got 60% of us that are asymptomatic carriers roaming the streets. If you don't get those people vaccinated, everybody vaccinated, this thing's still going to spread like wildfire. And I get protecting the people that are most susceptible to it first, but we still got to get rid of this thing. The asymptomatic carriers need to be, in my opinion, more of a focus here. If we're going to get rid of this thing. And I don't feel like there's any reliable way of integrating, let's say, restaurants, opening restaurants back up again, or like, let's say the churches, or safely to open a church, or to, let's say, a show at the Sanger. I don't know anybody's going to take that risk. Like, maybe there are, like, more people than I can think of that would say the hell with it. I'll go sit in a Sanger with thousands of people. Well, and just take my chances. Well, if you know that 60%, up to 60% could be asymptomatic carriers, I don't know how many people would be excited about doing that until there's a treatment or vaccine. So,
yeah. Well, so of the 300 and whatever page plan, I clipped this one so I could quickly get it for us. This is what they have for getting the community by scaling back or unlocking. That's what's in this 350-page document. The decision to discontinue community level measures must balance the need to lift individual movement restrictions against community health and safety. Premature removal of containment strategies can increase the risk of additional transmission. Decisions should be based on evidence of improving local and regional control, such as consistent decrease in the number of confirmed cases, reduction in the number of probable or known cases, effective protective countermeasures are in place, high coverage in the pandemic influenza.
But we don't have
vaccine. We don't have.
We have no way of measuring reduction in number of probable and known cases because we don't know,
and we don't have the vaccine.
And we don't have a vaccine, so we can't even begin to scale back according to this guide, right?
Yeah. And again, this is for
why hasn't somebody in the media pulled this guide and asked this question to the governors and the president? Excuse me, we have this book that y'all published back in 2005 that deals with this exact situation. I'm guessing some smart folks came up with this stuff. And my suspicion is you can turn to the back or the front of that book and it'll tell you 1,000 people's names that all have MD or PhD after them. They came up with these rules. And they, in a non-emergent setting where they were level-headed, they came up with these rules and said these things. Why aren't we following these rules?
Yeah, or somehow applying the part that is applicable. I mean, I know this was for influenza, but here we are, it's a pandemic situation. And it's
a lot more dangerous, by the way, than influenza, contrary to some people's beliefs. All right, so well, that's an important page. Are we going to link that page to the?
I can get that page, but we will link the whole document. Because
I'm going to tweak that page. Actually, I'm going to tweak that page and tag everybody that I know is in charge.
Okay.
And say, all right, look, folks, this is something you need to be looking at, and we don't have answers to. items 1 and 2 of the 3.
Yeah.
So I'm not
Yeah.
too sure we should be doing anything at this
Yeah,
point.
I think the impressive thing about this whole document is historical purposes, looking back, 15 years ago, what was the mindset, and, here we are again. But number two is, it really doesn't hold any punches. It's written for the people for the medical professionals, for the scientists, for the elected officials. It's not written for someone to read at home and make them feel good. So
Right.
my recommendation is to read it so that you don't feel good.
There's no
Like-
politics involved in it.
Yeah. And so I and there's no misleading headline or anything like that, or a partial headline, clickbait, nothing like that. So I recommend, thumbing through this thing. You can just look at the title at the top of the page and say, I'm not interested in that. But then you start seeing some of the ways that they're talking about rolling these things out and say, wow, we just did that, or we're in the middle of this. And, it's a playbook to a certain degree. And again, I know it's flu, but it's still, there's a lot of overlap. So that's something that I found very interesting. I spent a lot of time reading on it last night and then again this morning. So
Okay.
And I'll make sure you get your isolated page out of the 300 so you can do your tweet. I'll get that for you. So all right, next thing up here. So moving along here, where are we with treatment possibilities? So this infographic I found, and we'll link it as well. So repurposed drugs, and it shows what the timeline is, how they think we could find repurposed drugs, in the next couple months. And then antibodies, we're looking at rolling those out by end of summer. And then vaccines. So that's
This
the
is not good
timeline,
news.
people. That's the timeline. And so there's 43 vaccines being worked on. I think that these numbers may have gone up since this actual infographic was made. But then it shows you kind of very easy to understand, we're using drugs that were originally meant for Ebola, HIV, malaria, and, are one of those going to be the resource that we end up going with? And then there's the antibodies where you're getting it from either another recovered person, or we're making them from mouse antibodies, or we're bioengineering them. And it's more than just collecting them from sick people. They're trying to get that. And then the virus, vaccination. So this is a pretty good infographic, but to jump onto the heels of that, I wanted to show people this, which is a pretty cool resource. And with this is, let me get this link up. So this Milken Institute is keeping track of, hold on, there we go. They're keeping track of it all. So all those studies I just showed you in that one infographic, if you go to here and you click on this orange tracker, they will show you the exact status of what's going on with every study. You can track along and see where they're at, what phase they're in. So this is one of the antibody tests. It's like kind of twitchy actually on the website.
It's blurry on my screen. Is it blurry on your screen?
No, let me try to zoom in a little bit.
Oh, okay. Oh, good.
Yeah. So anyhow, if you scan across there, this is not as easy to consume, but it just shows you that there are people staying on top of this and I guess holding these different tests accountable to say, hey, where are you at? We want to know.
But any of these are going to take a year or more to get completed, right?
For the vaccines, very likely, which leads to the next link here that I'll put up. And you mentioned it last night, and it's this right here. Oh, no, that's the wrong one. Sorry. I had too many things today. Open up. It's this right here. So trying to fast forward this whole thing. So you get to a point where, you're testing like monkeys or mice and things like that. And that's typically how these things go. And then you get to phase 3 and you do human trials. They're talking about basically skipping some steps and going right to people who are volunteers. And they're basically saying that this argument is, we think that we can do this. We can accelerate the evaluation of the vaccines and reduce the global burden of this virus. Hence, the morbidity and mortality of the planet goes down. The offset is we're going to have some volunteers who are going to be electively allowing us to inject potential live vaccine or fragments of the virus into them. And and they may fare well, they may not. The idea is we get young, healthy individuals to do it initially to say, okay, yeah, this shows some promise, and then start getting some of the more at-risk individuals and trying it on them, and like basically have them ready to be hospitalized and treated with whatever other resource we have at the time. I mean, this is like scary stuff. Like this is from the movies, I think. But that's how extreme this is getting, to try and contract that timeline that you saw on the vaccine on that first infographic that extends
So
till
that
over
would
a year from
contract the
now.
timeline from 18 months to what?
It would probably chop off at least 6 or 9 months, I think,
Wow.
because this is a big
That is
part of it.
significant.
And so it's worth, you know, there's people, the Journal of Infectious Diseases saying, let us do it, you know, like give us the high sign and let us have these people sign waivers from here to infinity, and we're going to start injecting them. But you know, but be mindful of the population they start with, and you know, it's going to be one of those things. Like I think of like you know, back this like years ago, the Tuskegee Institute.
Right.
It's sad. A sad part of our history was doing vaccine tests on people who didn't know.
Right.
This would be much different, but it is got a similar flavor because you're giving people live
Purposely
vaccine.
infecting people with a virus.
Yeah. So that's on. That's, I think, could contract that infographic if we get to that point, and hopefully, I mean, selfishly, I'd like to see it happen because I think it'd be a way to flex the innovative muscle. But you know, at what measure? I guess, you know, yeah, there's an off chance that some healthy volunteer could not survive the trial, and then yeah, you feel bad that one individual didn't make it. But man, if you think on a global scale, like, you know, hundreds of thousands of people were able to benefit from it, like, you know, hey, that's it took one
I
for the
guess the
team.
problem I've got is if it's a large percentage of people that are asymptomatic carriers, and so you pick 10 people to be in the study, or 100 people, whatever the number is. If 60% of them, up to 60% of them are asymptomatic carriers, how do you judge the effectiveness of the vaccine? Is just
if they made the
you
antibody.
don't get the virus at all,
No,
or you don't get symptoms from the virus?
So the vaccine tests are testing whether or not the vaccine works. So you inject something into the person, and then you test their blood at certain intervals afterwards to see if their body makes the antibody.
Oh,
which is so you're not measuring how they feel. I mean, yeah, it's going to be part of the study. Like, we want to see if they feel bad after this, but measure the effectiveness of a vaccine. It's what is the antibody response to see if your body says, hey, we just got something just offended our system, and now we're going to make this antibody so it doesn't offend us again. That's what you want. That's what the flu vaccine does every year.
But even with infected people that have symptoms, do they have any level of antibodies?
Yeah, that's what they're doing. That's what, like,
right.
Like,
so my question to you is, what level of antibodies is enough to justify, to say that the vaccine works?
There's certain measures, because there's a couple different there's an acute phase antibody, and then there's a long-term phase one. So I'm sure they're going to look at all of that, and that's how you say whether or not it's effective. If you only make one of the antibodies or have a weak response, yeah, your body made antibodies, but not nearly enough. So that's not a good vaccine. We need to come up with a different mixture. And so they're using components of the RNA, that's the genetic material of the virus, and also components of the corona, the proteins around the virus, because those proteins around the virus can stimulate the antibody to be made in the body.
Okay.
So it's what they call like recombinant vaccinations, or they do like partial live ones. So there's a whole variety of testing that they need to do. Like, not every vaccine that's currently available to us for all the other diseases we try to fend off for the population have come from these similar, like, hey, which one works best? This one's a live attenuated vaccine. This one is completely it's just the protein. There's no DNA in here or RNA in here. It's just the protein, and that does it. That does the trick. So that's what they need to figure out, that balance. And so that's why you do these trials, to say. And so I would say if they had 10 people in a trial, then all 10 probably wouldn't be getting the same vaccine, because they'd want to measure the difference between which vaccine created the best response in whatever individuals.
Gotcha.
So,
all right. What else do you have for us today?
Let's see here. I think I had, let's see. The human challenge I talked about. Um, I guess I'll share this last thing on here just because it commented about the repurposed drugs, and I kind of slipped up and showed it there at the end there. So the pharmacologic treatments for the coronavirus, and I liked this again. This is from JAMA. I like this because of this diagram right here. And we showed something like this last week. And so the little grayed out boxes with like in the center there, it's a chloroquine and hydroxychloroquine. It shows where in the whole process it would have an impact. The authors of this seem to think that the remdesivir, the antiviral that was meant for Ebola, they seem to think that shows the most promise at the time of publication here. But these are the 7 drugs, and they're basically all repurposed drugs. Like these have been in use or in development for another intention, and we're going to try and see if it can apply to this virus at this time. So this is just another way to digest this, but to see it coming from a reputable source like the Journal of American Medical Association, I think is worth it. And so they say in here, the pandemic represents the greatest global public health crisis of this generation, and since the pandemic influenza outbreak of 1918, that's what they're comparing it to. The speed and volume of clinical trials launched to investigate potential therapies highlight both the need and capability to produce high quality evidence even in the middle of the pandemic. No therapies are effective to date, and that was published within the last few days. So that's why it's saying, you know, we got to look at these drugs that we've had that are repurposed, because that right there, you know, we looking about. That's why on that one infographic I showed you, the repurposed timeline was like months, not a year and a half.
Weeks.
So yeah, so can we get a shortcut here to temporize things while working on the vaccine that you can only fast forward so much? Right. So this is just a good explanation about, you know, repurposing drugs, and I think it shows again the innovative muscle of all the scientists that are way smarter than us that do this stuff day in and day out. They've been doing it even before they knew about a pandemic. They're preparing for one. So right. It's something to kind of look at again historically more than anything too. So that's kind of what I had.
That's enough.
We had one other question that I fielded, and I said I would give the answer to it today. So there's question of you know, where are we in comparison to the flu? And we talked about this last week. So flu season is technically over. But to give people some big broad numbers and say, you know, what did the flu do this past year? They're estimating that the flu in the United States is somehow tied to between 25,000 and 60,000 deaths in the United States. And right now, in the United States, we're at 44,000 with the COVID. So it's apples and oranges a little bit because flu season's like twice as long as what we currently are in. So the COVID is probably much worse if you contract it down to the timeline that we know right now. They're saying flu season between October 1 and April. So that's, you know, a much broader, that's a 6-month cycle. So we've only been in this for what you said, 6 weeks, right? So stretch it out and say in 2 months, 45,000 people have died versus 6 months, 60,000 people maybe from the flu. So it's apples and oranges, but to let you know that, you know, they estimate, the CDC and estimates that anywhere between 25,000 and 60,000 deaths are attributable to flu. Now add to that, we have COVID along with it. So when people say, oh, it's COVID's not as deadly as the flu, I think it is, and if not more. So I just wanted to answer that out there, and we can give that link as well. I think we're gonna have like 15 links today. Sorry, guys.
Yeah, it's okay. So they want to click on them, they can. If they don't, it's there.
Yeah.
Because they will probably come back though once they realize how important this stuff is. Like yesterday, we went over this stuff, and I heard 4 or 5 of the things, like I said, on the news, and I'm like, oh, heck, we've got the resources and the data to back up all this stuff. So it might be a good place for people to go even after they've watched the news. So, all right. I have a feeling though, people are going to be asked to go to work next week, whether they work in a retail store or they work at a restaurant that's maybe trying to do some kind of distance eating. I'm not sure what the governor's going to end up doing and allowing, and what the mayor's going to end up allowing. But I have a feeling that a lot of people Sunday night are going to be stressing out about, oh my God, I got to go to work tomorrow, and my employer's making me go to work with all my workmates. How can I protect myself? So my hope is that we, between now and Friday or so, we can start compiling a list of things to do to protect yourself if you have to go to work next week. From a legal standpoint, I also want to make it clear that anybody that's high risk, if your employer is making you go to work, I think you need to make a record of that. Okay. In other words, send an email and say, listen, you know, my privacy rights protect my private health information, but I feel compelled to give you a piece of that information. I mean, somebody could have asthma and be in a high risk group, or be over BMI of 31, which 30% of the population is, and be in a high risk group. And I think that businesses forcing people to come to work without taking all kinds of precautions for their employees, and even if they are, they're still making them susceptible to being sick. Because if I'm not going to open until there's adequate testing, and so, but if I was a business downtown, for instance, that was having people come to work, and you're going to squeeze them into that parking deck at Jefferson, or you're going to squeeze them into the parking deck down here at Government, and you're going to say, okay, park 6 inches from another car, and then slam them all in there together, and y'all come to work at the same time, between 8:30 and 9 o'clock, and use the same elevator in the parking deck, use the same stairwell in the parking deck, use the same sidewalk to get to the front door of your building.
Doorknobs.
When you get to the building, get in the same elevator, come up to the office, and then breathe in that space for 8 hours. And then you as a business are going to say, okay, I'm all right with risking these people's lives because I want to make sure that our economy gets back sooner. I don't know. The lawyer in me wants everybody to be careful with that decision, okay? Because I can see a situation where somebody is forced to go back to work despite telling the employer that you're in a high risk group. They end up getting sick from a coworker who's asymptomatic, and heaven forbid they end up in the hospital or ICU or on a ventilator or worse, right? And the families come to see me about that. And let's say it's Gulf Power, or I'm not saying Gulf Power would ever do that, but let's say it's a big business that's making these decisions. These folks need to pay attention to this stuff, right? And you can't just open when the government's own guidebook to these pandemics says to reintegrate without these things in place is risking people's lives. You didn't say it any better than that book says it, Dr. Malone. So not taking anything away from you, but that book says all we need to hear. So, yep. All right, long and short of it is, thank you very much for all the helpful information tonight, Dr. Malone. And we will see you tomorrow. If anybody has questions about this video, Dr. Malone, the studies he shared, you can ask us online or call us. If you have issues, personal injury issues with car wrecks or medical malpractice issues, nursing home issues, elder abuse, accidents on the water, you can find us on the web at zarzaurlaw.com. Our phone number is 855-HIRE-JOE. That's the vanity number. We're down here in the middle of Pensacola, the heart of Pensacola, at Romana and Palafox, and we're working remotely at full speed. And so you can get us at any time. We will see you tomorrow, and y'all stay safe. Thank you, Dr. Malone.
Bye now.